the backwards and forwards is going? Put it forward one slide.
No, it doesn't really work.
Okay.
Let's see now.
So
no, yes, it works.
Okay,
fine.
perfect.
Okay, it's working.
Okay, so you can just interrupt me if the technical things don't work, and we'll have a break or something, and I'll try to figure them out. But let me just begin now. So the background for this seminar, and I guess also why we got asked to speak here, is a book that we have just published called Addiction and the Brain: Knowledge, Beliefs, and Ethical Considerations from a Societal Perspective. And this is a product from an international research consortium called the A-Brain, which has been going on now for 4 years. And actually the collective part, the consortium part, has ended this in March, but we got a little bit more funding for the Finnish part, just some news some weeks ago. But the book is somehow a compilation of what we have done and produced in this consortium. And the book concerns the functions and usages of references to the brain in different contexts. And it took a while for us to figure out how to conceptualize and describe the phenomenon that we are studying, since there were no good social theoretical concepts for the references made to the brain and what it means. So we finally came up to the solution that when we refer to the brain, we are involved in an epistemic project. And we call this epistemic project the Epistemic Project of Addiction in the Brain. Here is some other text just as a background, and this is the book, but we have also published other pieces about understandings about the brain and on the brain in different communication contexts and settings. So the definition of this epistemic project of addiction in the brain is that it stands for the sociocultural production and dissemination of the notion that the brain plays a role in addiction. And another definition that we have used is that is any and all activity which communicates an understanding of the brain playing a role in addiction. And I shall explain why it's so important that it has this vague and open meaning. The crucial thing is that when we are studying the EPAB, we are not looking for any specific model or theory among the study participants in our materials. We do that in those presentations we are keeping today. So, but in theory, this is our constructionist view. We are more looking how the phenomenon materialize in different contexts and settings when we communicate. So this sentiment allows us to approach the brain as having significance for how we conceptualize addiction without prior man-made assumptions on realities. What this means is that the problem with measuring support for models and theories is that we force our own models and reality onto natural speech or text. So the EPAB allows us to be structuralist and ask how this project comes about when we communicate it. And the focus is not on what addiction is, but how it becomes, how it comes into being. And addiction research and addiction researchers are very much involved in the making of addiction by talking about it, researching it, and being specialists and experts. So the EPAB is situated in a social cultural theory of addiction that entails all other theory, as theorizing in itself is part of the coming into being of addiction as a phenomenon. So our focus has been these are just some examples of some questions. In what sort of context is the brain referred to? What roles and functions does it have in communication and conceptualizations? How can the Epistemic Project of Addiction in the brain help societies, people, and individuals? And when does it not help to refer to the brain? So the data that we have are 6. We have focus group interviews with outpatient treatment clients. Mihail is going to talk about that today. Prevention programs and communication, researchers, scientists, and experts. Doris will speak about that, a survey with researchers internationally in the addiction field. Then we have the field of substance use and addiction services in Finland. And then we've also looked at mass media portrayals. And then there's a small side study in Germany with representatives of the juridical system. So these 3 we are going to focus on today. So I'm not going to talk long, but I'm just going to as a peculiarity, or this might interest you, to see how we saw that the materials and the ways in which the brain is referred to in these different materials, how we could put them in different places on a spectrum, which goes from the really neurocentrism and positivist outlook in the one end, and the more critical outlook in the other end. And it turns out that the popular media was really, really neurocentristic and didn't take really, didn't problematize at all any of the brain-based notions. And in the other end, we had treatment clients that would only pick parts of the brain-centered understandings in order for them to be, or just those that serve their biographies that help them recover or understand themselves as people. And Mihail will speak about some interesting things about that later on. And addiction scientists or researchers were somehow there in between, aware of both. And neuropsychology-based prevention was more to the neurocentrism end, and the addiction service system in Finland, or substance use and addiction provision service system. It's a very wide group of people. Sharon is going to talk about that. They are somewhere more in the critical end. So these are our presentations, and in the beginning I spoke about the EPAB. I think you will find that this is more classic surveys, social sciences and social epidemiology, quite traditional stuff, but I think that you will find that there is some interesting results we have found, and that there are very much to discuss and also think about more what the results mean. Doris will speak about the survey with researchers. Sharon will then speak about the mixed method inquiry into the Finnish substance use and addiction service provision field. And Mihail will speak about the focus groups with outpatient treatment clients. Please check out the book. It's published with Palgrave Macmillan. Okay, I think I stopped sharing so that the next speaker can take the floor.
Hang on. Doris, I'm trying to share with you again so you can take control.
Does not show. I only see Matilda at the moment, but I cannot see anything else. This one perhaps? No.
That seems to be working. I don't know.
It does not show any. Show up here. Is it this one? No.
Yeah, can you go into presentation mode with that?
No, I can't. I don't see anything right now.
Okay, can whoever's sharing
We
the
tried
screen?
that out before.
Yes, I know.
but-
But I can only share when someone stops sharing.
Yes.
So if you just stop sharing, I will share with you and you can take control. Okay, so you should be able to take control now. No?
No.
Sorry about this. Give me.
Somebody has put a PowerPoint presentation up, but not in presentation mode. Who's done?
Yes.
Doris, have
That you, Doris.
This is my presentation, but I
Oh,
didn't put
oh,
it
no.
up there.
It's gone again.
But I'm trying to. Okay, now you should be able to take
Yes,
control from me.
This is it.
Ah,
Okay.
can you see that, Doris?
Yes, I can see it, but and I can take control, hopefully.
Yeah. Okay, I'm gonna.
Go back to the first slide. So this is it. Can you see it? Everyone, I hope I can move it also.
Yes,
So
we
I'll
can.
just start. So thank you very much, Matilda, for the introduction to the project and the book. And I'll now share with you parts of our empirical work, which will answer the core question of the addiction theory network, actually. What do researchers think about brain-based explanations of addiction? Why did we survey researchers? Because it's important what they say, and it affects a lot. For instance, policy debates, public perception, and ultimately addicted persons themselves. Just a short recap of the broad range of health research impact. We usually focus on type of problems and knowledge and research methods, but it's much more, such as policy, service, and society. Only very briefly, so that you know why all of us are important and what our work does, actually. How are researchers' opinions expressed? How can we assess them? Usually we study papers and possibly conduct reviews, and we exchange our views via conferences, but there are surveys too. Very few on the brain disease model of addictions. We found a study of 31 Australian addiction neuroscientists and 20 US American nicotine research scientists. So we need an international and multidisciplinary survey. This is, to our knowledge, not available. When trying to conduct it, we were faced with the first major challenge to define who is actually an addiction researcher. There is no title or academic degree. It's not limited to one or very few disciplines. There are unclear boundaries to this group. So we had to apply a feasible and pragmatic approach, and we wanted to include participants from several sources with the broadest possible range of academic backgrounds, with various attitudes, pro, contra, or interdisciplinary, and also, of course, international. What did we do? First of all, we compiled all editors, editorial board members of journals, peer-reviewed journals in the field. And we expanded this primary sample with pro, con, and interdisciplinary participants, the letter signatories from the letter to the editor of Nature, which you probably all know, NIDA advisors and reviewers, and speakers at an explicitly interdisciplinary conference. Participants were asked to add snowballs, to name snowballs, which were then also invited. And then we controlled for duplicates, deceased persons, which were quite a lot, obviously, seems to be a dangerous job, consortium members and so on. And we came up with a primary sample of 1,440 researchers from 49 countries. The questionnaire was based on a literature review and the extraction of themes from 3 different databases with different foci. So we've, and in the end, ended up with a questionnaire structure asking about addictions in general, and the part asking is implicitly about brain-based explanations of addiction and information exchange networks and more. This is more about the coming into being, what Matilda mentioned. In this presentation, I will refer to the acceptance of the concept and the dominance in various groups. We collected data via Lime survey online in 2019 and invited participants personally via mail. They had to select a substance at the beginning from a drop-down list or several substances or behaviors, and could also add personal other options that were not provided. The answer options for the questions were either like a types case with an additional free text field for further comments, or else open-ended questions only. Those were not substance specific. We had 190 participants, which makes a response rate of 13.19%. This is slightly above what we expected. We looked into literature and saw that with a similar approach, there was a response rate of 10%. So it's slightly above, but it's not a lot, and it's of course not representative. The participants came from 29 countries, with the vast majority from Europe and North America. The Anglophone countries make up more than 60%. Unfortunately, there was no one from Africa. I regret that very much, because we had 11 persons in the primary sample from 4 countries, but no one followed our invitation. And I cannot skip to the next slide because I cannot see it here. Where is it? No, I can't go on, Derek, because, no, I see how to do it now.
Okay, sorry.
Here I am. These are the academic degrees of the participants of the study, and it shows we're truly interdisciplinary. Then the things you always wanted to know, but no one ever examined it. What do researchers think of about the classification of substance use disorders as brain diseases or brain disorders? Do they share the view? What do they think in particular about its evidence base, about the issue of oversimplification and neuroplasticity, and do they consider it helpful? And is it the dominant view in science actually? And what about society and treatment settings and affected persons? So first of all, we see that about 60% say they share this view, but 40% do not. This is a slight majority, except for gambling. We see this for gambling and smokeless tobacco sometimes, in some of the other questions too, that there are deviations. We cannot really say whether this is because it's a behavioral addiction compared to substance addictions, or whether this is because smokeless tobacco and gambling have very few participants, and this might sort of bias the results too. We cannot say this, but we observe it, and it leads to further questions. In particular, about 60% consider it supported by evidence. The percentage is similar to the previous one. But more than 60% say neuroscientific findings are better explained by the normal neuroplasticity of the brain. And 80%, more than 80%, except for gambling and smokeless tobacco, consider it a complex phenomenon, an oversimplification of a complex phenomenon. But nevertheless, nearly 80% say it's helpful to understand substance use disorders. Regarding the acceptance, it's interesting. In science, even though only 60% said they personally share this view, they consider it the dominant concept in science. It's about 80% here. It's not the dominant concept according to researchers in affected persons, and even less so in society, which is interesting regarding the results Matilda presented and the media presentation. And there are mixed results for the treatment settings, 50-50, about 50-50. We also received free text comments from 32 participants to frame the results. 14 of them emphasized the oversimplistic nature of the concept. Others mentioned the problems with normalizations of neurobiological findings and pathology and neuroplasticity. And also quite a few mentioned the confusion of causality and correlation. There is a correlation of brain changes with addictions, but it's not the cause. And there were also quite a lot of interesting marginal themes and single mentions, which I cannot explain here in depth. The conclusions. There are lots of conclusions to draw from that and also further questions, but I think one slide should not contain more than 4, so I had to decide which ones I consider the most important. First of all, we can see that a simplistic view is rejected and a complex understanding predominates, in our sample at least, in which the brain plays a role as well. This is also supported by other results from our survey, which I do not present here, by the way. About 80%, this is what we saw, consider brain-based explanations dominant in science. What does that mean for future research priorities? It is an oversimplistic model. This is what participants think, but they at the same time consider it helpful. What about the strategical deployment of these explanations? We saw this issue mentioned in the review of treatment providers, but we can also go into depth there and consider what this really means. And then there is, of course, a lot of implications regarding the dominance or non-dominance in treatment-affected persons in society. Is the perception of the researchers the right one, or do the other groups perceive it differently? This is one question. But we'll hear more about that in the next presentations by Michael and Sharon on these target groups. These are the references, and I thank you for your attention to this brief walk through the main results, or some of the main results of our survey.
Okay, who's next? Thank you very much. So Sharon, is that you? Oh, Michael.
I can continue since this is survey results we are talking. So is that okay, Michael?
Sure.
Yes, sure.
Okay. Should I share my screen here, or do you want to share, Derek? How you?
If you can share, that'd be easier. Because yours came in a funny format, so I couldn't really open them.
Yeah, but yeah, I don't see the share screen option here. Okay. Yeah.
Oh no, it's working. It's perfect.
Can you see it?
Yeah.
We can
Okay.
see, but it's not in presentation mode.
Is it now?
It is
Yes. Perfect.
Thank you.
Perfect.
Okay, so I will continue with the Finnish survey part, as Doris already talked about the international survey, so it makes sense to talk more about the Finnish result here. I'm Sharon Basnev, and I'm a postdoctoral fellow at KMH, Toronto, Canada, and I would like to thank all the audience, international audience from different places. So greetings to everyone. So let me continue with this short presentation. So the main aim was to capture the Finnish substance use and addiction service field in a broad sense. And we were targeting 5 different stakeholders from different policy making, service planning, prevention, information, education work, treatment, so and welfare support structures. So altogether, there were 5 different sectors, and we had a overwhelming number of stakeholders who participated, 997 stakeholders, and they filled in 82-item questionnaire. So I won't go in much into details of methodology, as it is same as Doris talked about. It was in line survey and remotely filled. And the main aim was to map the view on addiction problems and system for dealing with them by the Finnish professional in the Finnish service system. And we used a mixed method survey, and there were lots of multiple choices and open-ended questionnaire for the qualitative information. So the main, I have few slides about the analysis. These were the more 6 different field of addiction the Finnish professional were dealing with in the survey. 87% were dealing with alcohol, followed by cannabis and opioids and so forth. So least for tobacco, but quite representative of all the fields. And these were we asked about different treatment choices of the professional. We have this data for each substance, like all 6 of those addiction field. But here is the mean average of all the addictions. So Finnish treatment professionals are mostly using this altered social environment, followed by the easy access to healthcare system, and life skills and habits. And we also had lots of open-ended qualitative choices for where the stakeholder mentioned about their treatment choices, but this is the quantitative part. So, and it's the same like Doris, we also had this 8 different types of addiction definition choices that we gave to the stakeholders. And for the result, what we got was this learned coping strategy got the highest percentage of choice for the Finnish professional, followed by emotional disorder, and the brain disease was the 3rd highest, and so forth, like in the graph. And this is the summary of the result that Doris also presented. We asked if addictions are brain-based diseases to our stakeholders, and theoretically, most of them, 90% of them, agreed that it helps to understand addiction, and they also thought this is main paradigm in science. But practically, if you see the ontological part, it's declining. Like in reality, it's not that much. It's declining, like in the graph. The main, also we have this qualitative materials where we talk about ontological aspects. We talk about different, we ask the stakeholders about the benefit of brain-based understanding. We ask about the general risks and so forth. And we also had this, these are all the qualitative information we had for the epistemological aspects, where we ask them about possible benefits, possible risks, and so forth. And the main conclusion here is that we have a strong dichotomy in Finnish substance use and addiction field service based for brain-based disease addiction sentiment. And the main takeaway message here is that Finnish addiction service system is not ready to welcome and implement a neurotechnological solution for dealing with substance use and addiction related problems. Even though we got the brain-based disease, they agreed that it is 3rd highest in the graph that you saw, but it is declining in reality in the practice. So the main conclusion is that stakeholder consider it to correctly conceptualize the addiction as brain-based, but ontologically speaking, many thought that service provision or the society at large is not ready. So like Matilda said, they are more in critical end. And it could be because we are discussing this because of the Finnish welfare society system. So like you see, the treatment options are more in the altered social environment was the highest. So that is also one clue here. And support of citizen as a responsible agent is what Finnish society considers the most. So we would like to acknowledge all our co-authors here, and yeah, thank you all my listeners, and we welcome the floor. We open the floor for discussion. Yeah, thank you.
Thank you very
Derek,
much.
do you want to share or do it myself?
Would you want to try and share? If not, I'll share for you. Let me just spotlight you.
Okay, give me a second to find my
Well, this seems to be working.
presentation. Wait, slideshow. I think now. Do you see now the slideshow version? So it's working. Good. Okay. So I want now to give you a short snapshot on the treatment part. So let's see how this EPAB turns out in the treatment setting, and I gave it the heading Agency Revisited. And I also want to acknowledge, besides the funding, of course, also Brian Pereira and Dr. Christian Hendershot, who helped a lot with the data collection at ChemH. And as my previous speaker, I would like to keep it rather short to give you time then afterwards for discussion. And the background is, and probably in this audience, I don't need to go too deep into it, that the BDMA discussion, pro and contra, is strongly built around the notion of agency. And in a very condensed, simplified way, the pro argument would go like this, that the hijacked brain liberates the persons with the addiction from the responsibility for it, which then reduces the stigma and then in turn also facilitates help seeking and also positive treatment outcome. And on the contra argumentation, if there would be an hijacked brain, this would question the human agency in our modern, postmodern society, where agency is a very important feature of citizens. And this questioned agency then would in turn increase stigma, not reduce it, which then hinders help seeking and also hinders a positive treatment outcome. And here in this treatment setting, we wanted to check like what is the role of agency then in the addiction treatment and recovery, like for the persons concerned with it and having the experiences of addiction and treatment and possibly recovery. And there's a wide literature on that, on narratives of recovery, how people are getting out of their addiction and into recovery. The data, method, and analysis I want to show you also like shortly. There were 11 focus groups interviews with altogether 69 persons, and we conducted the interviews at the Center of Addiction and Mental Health in Toronto, Canada. And these persons were like either still attending the treatment there or they have attended it before, but they were recruited via ChemH. The interview protocol we used was like a composed protocol with discussion stimuli, where we showed them, for example, like media reporting headlines or media reporting pictures and images that were in the media. We also asked them direct questions, and we also engaged them into a small group task to work together. And basically we worked from like an initiating phase, giving like very broad questions and very broad possibility for discussion on the discussion stimuli, looking at the understanding the brain's role in addiction, what are the practical implementations or implications also for the policy from the perspective of the interviewees. And then we also specifically looked also into responsibility and stigma. And the analysis was then a narrative analysis facilitated by systems theory. So basically we looked at like, how does the interview stimuli our questions and so forth, and the group task resonate in informant's addiction narratives. So how they were talking about these impulses and stimuli, where we showed them, for example, like brain images or media reporting on how cocaine would be the same effects, would have the same effects on the brain as like being in love and so forth. So how do they take these external like images and impulses from the interview into their discussion on their addiction recovery and their addiction treatment? And the results, in very short, the interview stimuli, they did resonate in 3 different ways. In one way, they were saying like, well, yes, they agreed with it, basically. There were also like active resistance against it, and also like some kind of undecided or pondering about it. And then like as a 4th version, and that then was somehow really interesting because we asked them quite specifically on the brain disease model or brain disorder model of addiction. There were also like instances of no resonance at all. So we asked them, how do you see this model? What kind of stigma this could create, for example, or and then they turned towards their own personal recovery stories or told about traditional models. So they did not, this interview stimuli did not resonate at all in what they were discussing about. So they were referring towards their addiction treatment and recovery the way they did probably many times before. But looking now a little bit into the how it resonates, there were the basically yes answers, which were a validation and self-assurance. So the explanations that addiction happens in the brain were for them like a possibility to be used in their narrative, to validate them and self-assure them, to explain to themselves and also to others why they have behaved in a certain way when they were still with the addiction. They also talked somehow, but not that very often actually, about concrete impacts, how such a model could work in actually helping against structural discriminations, how it could be a good thing for getting coverage from health insurance, for example. They also like distinguished themselves or not distinguished themselves by referral towards the brain. So they talked about, for example, the normies, so the other persons like who have no problems with addiction, who are not in recovery. But then they said like, well, but basically our brain works exactly the same as theirs. So it's just like for us, it went into a different direction. And finally, they said like, well, yeah, this is probably true. The brain has an effect on addiction, but they also said like, so what? It doesn't have any effect on my life. It doesn't help me. There's no difference for myself. Even stronger, the resistance happened in a way that they exemplified quite strongly that everybody's an individual. They have their own biography, their own lives, which led them towards their addiction. So this is not about the brain. They also insist on agency, and in that way, it was an interesting way. They insisted on agency, not in the way that I said, like, okay, I could decide what I wanted to do. But they're saying like, okay, yes, the brain might be hijacked, but there's also my heart in it. I have my emotions and myself, which then is constructed as their agency. And finally, the undecided one, where they were pondering, okay, yeah, there might be some truth in it, but well, I heard also it's about social issues. It's about genetics, for example. So they were not taking either or side, where they were like pretty strong on it, and that was throughout many of the interviews, actually, many of the groups, was they said like, okay, yeah, well, maybe the brain, yeah, that might be an issue here, but the disease part they didn't like at all. They say like the disease one, that's stigmatizing. So here they were quite clear, and there's also like studies from Australia, which where they found actually the same with persons in addiction treatment. Summing this up in the conclusions, I would to point out like two things, looking at the concept of agency and looking at the concept of stigma. That the concept of agency is not only the question of autonomy, what people are doing, but it's also a matter of biography. And so the autonomy reduction during the let's say like active addiction phase of someone's helps then in later stages to construct the biography, to construct the agency. So saying like, okay, I behaved in that way beforehand because my autonomy was restricted because I had troubles with my brain, so to say. But in later times, retrospectively, that gives the persons in treatment the chance to construct an authentic biography. And also the concept of stigma, I would say, needs to be like looked at like more specifically. Whereas the BDM Pro persons, so to say, very often talk basically about the public stigma and structural discrimination. They normally oversee the self-stigma. And similarly also the persons who argue against the BDMA. Normally the self-stigma is not so much talked about. And the relief from responsibility risks definitely increasing the public stigma as concerned towards the informants, towards the persons in treatment or shortly after. But on the other side, it can help in reducing the self-stigma. So it helps them to restructure their own self-identity and in that construct an authentic biography, and in that also construct agency. So they use the brain like as a symbolic value when it is suitable for them, quite strategically, but then also they have no problems to resist this model, or there are also instances where they just like did not talk about it at all. They went on their narrative, their addiction narrative as before, without taking any reference towards the BDMA. And looking at it, and this is more like when I was like doing this presentation, actually, it seems that it's the temporal dimension seems to be crucial on like how the BDMA affects at different stages of addiction. Is it like retrospectively, and then how far it is looked at the different stages, like just thinking of the landmark paper of Davis on drug talks, drug speak, how through the different stages, the narrative on addiction changes. So what effect the BDMA has on addiction then also changes throughout these stages, throughout the temporal dimension. Okay, I think I took already way above my 5 minutes, so we'll end here, and thank you, and I think we are all ready for some discussion.
A big thank you to all the speakers, and now, Michael, if you could just stop sharing.
Is it now? Did it stop?
Yes, it has. And
Good.
can we go to Paul for our first question or discussion point, indeed?
Thank you for the presentations. I was particularly interested in the diverse role of the brain disease model in either explaining the causation of addiction or the problems that people are facing, and its role in treatment. Obviously, there's a diverse thing. It can normally in a medical model, what is the cause also it partly defines how the condition should be treated, of course, by taking away the cause. And did you come across, obviously this is not the case when we move into a disease like addiction. And do you have any ideas of how they think about this? How could you take away the cause of an addiction when it's situated in the brain? And does anybody can comment on that?
Doris, your microphone is muted.
Sorry. So now I could maybe contribute. We also asked the researchers what they think about the causation and listed a lot of possibilities and also allowed them to add further ones. And the brain disease as a cause is one of many. They ticked nearly all of the provided causes. So it's a really complex issue. And this is also reflected in what the researchers think how they should be treated. This is another question we're currently analyzing and trying and compiling for a publication. So this is, in the view of the researchers, one of many causes and needs to be a part of the intervention, but not the only one, like, for instance, pharmaceutical interventions. But maybe those who interviewed affected persons in the treatment system might be able to say more.
Yeah, maybe I can say a little bit about it. There were, of course, the discussion in how for like medication or something could help and how great it would be, but they were super skeptical about it. That's something that it could be just fixed by the medication. And also like thinking about how they constructed their agency, like being based in themselves. I would now interpret it in that way. They would be quite critical about just being their brains. So they were quite eager in also like explaining and telling that in what ways they are more than their brains. So this is only one part of their problem. But it's not the core. The brain is not the core of their self.
Yeah, if you talk to Nora Volkov, she will tell you it's either a constitutional makeup of a brain which predisposes a person to addiction, to an addiction. But at the same time, it's also an acquired state. So the brain changes as a result of using these substances or gambling even. So did your participants comment on that? What kind of, how much is it constitutional? How much is it acquired during the course of the use?
We did not ask that. We don't know. We know that they consider it as part of the causation, the brain changes, but not what is hen and what is egg, so to speak. But the comment that of the confusion of correlation and causation, that hints into this direction. There's a correlation with brain changes, but it's not they might not, or they are not the cause. This was the comment of quite a few participants.
Okay, thank you. Can we go to Lee next? Let me just spotlight you, Lee. Hang on. Okay.
Yeah, thanks for the very interesting talks. It's following very much on the last question. The dimension I'm most interested in is the sort of voluntary, involuntary attributions. And the brain discourse is normally tied to an involuntary psychological account. And it's kind of mixed, you know, you've got the biogenic causation and you've got the involuntary sort of packaged together. So I've been sort of wrestling with how to sort of segment the two apart, and I've been focusing mainly on the voluntary, involuntary dimension and trying to push the brain piece out. But I mean, to what extent does your data sort of pull out the whether people thought that the addiction was driven by involuntary or voluntary or involuntary processes, irrespective of the brain?
I'm always the first one now, but I can answer for the researchers only. We asked them whether they think addicted persons are responsible for their conditions and for their actions. And the vast majority considered them responsible for their actions, more than 80%, but only about 60% for their conditions. So this is part of, yeah. This would be, if you apply this Brickman's model of helping and coping, it would be an enlightenment model, but I cannot explain it now here. It would go too far. This is not what we would expect from a purely medical view on addictions. The classical brain disease model of addiction would say not responsible for actions and not responsible for condition. This is not what the researchers, the majority of the researchers in our sample, I have to say it like that, thinks. They consider the brain, that the brain does play a role and that there is a medical component, but it's not basically, that does not reduce responsibility.
Because I've heard within substance users that they vacillate between a voluntary and involuntary account depending on the needs of the circumstance, whether, you know, parole officer it's involuntary, a caseworker it's voluntary, or whatever. So did that get revealed in this data?
At least in the Finnish, in the open-ended questions with the Finnish service providers, they reasoned back and forth so that exactly as you describe it. So and the thing is that this makes it so interesting that thanks to asking qualitatively people, we got another picture of how actually they reason around these questions. Because first, if we would only look at the our figures that they agree that addiction, something's happening in the brain, but then when we start problematizing, they start problematizing when they are allowed to talk freely more, and they wanted to explain what they meant when they had, you know, when you partake in a survey, you often get very angry because there's not the alternatives you want to say, and then you want to explain. So they had a lot to explain in the open-ended comment fields, and there they would talk about this voluntary and involuntary treatment, also the kind of risks that the brain disease and diagnosis will bring with them, and so forth. So it's really interesting that something can be true that we as researchers have somehow construed as impossible to be true at once. But in fact, it's a free world. You can think that something is true similarly, you know, at the same time, without any logic, because this is what human beings do. So yeah, they reasoned both ways.
Also, when looking at the treatment, persons in treatment or shortly after, there was a similar way to find. I mean, some were like talking about and pointing out, like, okay, when I started to take drugs, it was my decision. I did it. Of course, I have to live with that. But then on the other side, there were also like other respondents like talking that they were like during the time when they took drugs, of course they didn't have any way to influence it, and then later on this can be they use it as a way to explain how they why they acted this irrationally, or why they acted against their better judgment.
Yeah, and to add to that, we also in our qualitative data where we are asking about the treatment choices, the highest choices was for altered social environment, even though there was medication, peer support, and list of 19 other treatment choices, but the highest was for the altered social environment. So maybe it is to do with the welfare society, and so yeah.
Thank you. Can we go to Richard next, please?
Yeah, thank you very much, all four speakers. Some very, very interesting material here. Two general points and then a question. The first one is that I'm not surprised that you've got a lot more richness from your qualitative data. I mean, it's very difficult, I think, to come up with a questionnaire of tick boxes where you can try and capture something about the range and depth that we're trying to get at here. So I'm not surprised that the qualitative data revealed a lot more. The second thing is I mean, it's not at all surprising that lots of people think that brains have got something to do with addiction. I mean, it's inconceivable that the brain doesn't have something to do with everything we do. My brain is responsible for every word that I'm now uttering. My brain is responsible for the fact that I'm using my eyes to see you all. I mean, it's so unbelievably self-evident that the brain has a lot to do with it. The question is about how useful it is and whether it's can be seen as a sole explanation. So what I'm interested in is, from all three of your samples, how useful did people find it? What was the utility of thinking about it as a brain, as something which was related to the brain? I mean, of course it's related to the brain, but is that in any way useful? What did people think about why it was useful, other than this thing about alleviating responsibility? Somebody needs to answer that question.
Well, we had a list there in one of the presentations there. They saw some benefits in the treatment or the service system for addictions in Finland. They saw that it.
How or why?
Sorry.
How or why? What was the benefit in
yeah, I'm just going to. They said that it could reduce stigma. It could be an opportunity to more equal treatment, because if you make a disease diagnosis, it's like, you know, a broken leg or something, that you will be treated like a person with a disease. Then it provides some measurable information about the addiction. They said, I'm not saying this now, no, but they said that. Then
hang on, from any qualitative info, I'm interested in all of these, but rather than just rushing through a list. So the first two, I mean, I understand. So yes, if people feel that it destigmatizes, then I can see why that's potentially has some usefulness. This extra thing about what? Sorry, can you say that third one again?
It provides measurable information about addiction.
Did from any qualitative work, have you any understanding of what that might mean? As I have no idea what it might mean.
Well, they think that neuroimaging is something that you can see and measure, and so that is their perception. But the most use they saw was a quite small and shallow use, and that is that they can tell the client that something is happening in the brain, so that it will be a pedagogical tool among others. But Anthony Barnett and his colleagues have already written about how professionals use these. They don't see a lot of use for these images. And I mean, they are professionals, hundreds of Finnish experts in the field. None of them were speaking of benefits of screening, diagnosing, treatment. Nothing like that. Only this kind of pedagogical tool, or then this kind of stigma and equal treatment, but they had the same stigma and it might increase stigma. So they could say both.
Yes.
Okay.
But
yeah,
I understand that it could increase it. But if it worked to reduce it, I mean, all three of those things are, whether it's a pedagogical tool, so you can say to somebody, look, you know, you've got to understand there's something wrong with your brain. It's not your fault. We can say in society there's something wrong with people's brains, so let's destigmatize it. But they're all different. They're different facets of the same one usefulness bit, which is that it might actually destigmatize addiction.
Can we go to? Sorry, Richard. Can we go to Franca, please? Because a few people have got their hands up. Franca, would you like to come in? You've just got to.
Yes. Hi, everybody. It's a pleasure to listen to you. I may be that I was distracted at the first presentation because of some problem with the PowerPoint with the view. So my question is about if you got any information about the influence of the treatment, national treatment system on the view that the people that you involved, both in the survey and in the focus group. So if you have also some comparison with other treatment system.
Would anyone like to comment on that?
I didn't understand. What do you mean by comparison of treatment system?
Okay, I mean, I think that the view that people working in treatment also is influenced by the kind of national treatment system in which they work. I give you an example. In Italy, the addiction treatment system has been built on medical approach mainly. Of course, now they involve also psychologists, a social worker, and so on. But the core is a medical approach. And I know that in the Nordic countries there is a prevalence of a wider approach, more open to different therapies and different approaches. So I wonder if you have considered also these different treatment, how these influence the people you interview.
Yeah, we also had policymakers, and we had a very wide definition of people. So we also had people outside treatment, service provision, like social workers and things like that. But basically, I would say that in the whole, they draw towards its psychoeducational and social seating of the problem. And we also speculate that it has something to do with being part of this Nordic welfare state. But it's the same with the clients in CAMH, that when you ask people to speak freely, they will start to line up according to what they have been schooled in the system of which they are part. So also in CAMH, they would start to talk about things as they are taught in that treatment setting.
Okay, thank you. Can we go to Bruce in Vancouver then, please? You're muted, Bruce. Just unmute yourself, please.
Yes, no, here I am. I wanted to thank the speakers very much for this careful research. I think this research very much needed to be done, and I think we all benefit from the fact that you have really done it. And what you have told us really is about the diversity of the way people think about the BDMA and everything else. But my question is not about how people think, but it's to the researchers about how you feel, because I hear this research and I admire the research. It's very important, but it leaves me feeling depressed. It leaves me feeling that we are, as a field, in a state of confusion, in a state of opinions which are not only diverse but fluid, and we're not really settled in any way, and that makes me feel sort of hopeless about our ability to function as a intellectual group, as a problem-solving group, because we have a big problem to solve. And so that's my question. How does this research make you feel?
Thank you. Who'd like to tackle that first?
Maybe someone else wants to go first. I feel like I have no feelings for this result. I am a very emotionless person. No, but I don't, because my aim is to problematize. So I'm just happy when things are there are problems. I don't mean it like that, but you know, as a structuralist, you know, I get very unsettled when there are too rigorous boxes, because I feel that when there are too rigorous boxes, we distance ourselves from the messy reality of addiction. But I am a little bit worried about still the ontological support for the BDMA among the Finnish service provider sector in a broad sense, because I still could sense some sort of maybe that they look up to neuroscience and they really thought that this could be the future. And there was still something like that, even though they tilted more towards being critical and they were very aware of the critical discussion, but still that made me a little bit worried.
But can I just pick
Thank
up
you.
on Bruce's questions? I mean, all this tension, I mean, everything seems to be, there seems to be this massive tension between, you know, responsibility or having a coping strategy as use, and thinking that the BDMA helps us to understand addiction. But I suppose, isn't this damaging to actually people who are trying to overcome their addictions? I mean, does it help them, this tension, being able to cherry pick whichever explanation they want at a given moment?
Yes, it helps, because then they have, you know, I don't think they themselves feel like it's a tension. Okay, they feel like, okay, but it's a messy, complex situation when you have addiction problems. I think it would be very wrong if we would like say that, okay, this is the right way to think about it. But I think in that sense, we need a broad repertoire of ways of explaining and understanding and dealing with it. But then it must vary between countries and systems what one chooses to implement.
Would any of our other speakers like to comment on how your research makes you feel?
Yeah, I was
back to Bruce's question.
Maybe not thinking about like how I felt about it, although that's an interesting question as well, especially for a qualitative researcher. But I'm not sure this is anything new. I mean, hasn't been addiction throughout the whole history always be like a very messy concept, and always there has been like the struggle between different ways how to understand it and to conceptualize it. So I don't know if in that way it's maybe not too much. It's not a new thing that we not really know like what it is. That's maybe part of the addiction concept itself, to turning around and trying to find the as true as possible parts, but very often like putting it together, you get from all the perspectives, get like some truth out of it always. The trouble only is if one of these models get like some kind of foothold so strongly that it now in a very practical way eats away all the funding, and also like gets the ears of the politicians and policymakers. That's maybe the trouble. That's now thinking about how I feel about it somehow. Yeah, and I'm concerned if this brain model gets too strong, if this natural allure of the brain model is so strong that the other models, the other understandings are not recognized anymore sufficiently. But I guess that goes all over this brain explanation. I mean, as Richard said, I mean, everything is connected to the brain, but they were like, at the last Finnish presidential election, they were talking about how the lizard brain is making some people to vote for that or the other one, and that's troublesome if it's simplified that way.
Thank you. Sharon and Doris, do you want to come in before we go to Paul again?
I could add that I had also had a lot of emotions in the course of the survey and the analysis, which I will not report, but there is one particular thing which makes me really feel uneasy. We heard from all stakeholder groups, also from the researchers, that they hold a complex understanding of the phenomenon of addiction. There are very few who say it's only a brain disease and this is the most important thing and we have to work on that. And also in our researcher survey, we made in-depth qualitative analysis about the implications of brain-based understandings. And we've got the feedback that they worry about a one-sided view and the neglect of other factors. And then when we ask about the dominance of the concept, 80% say that it's the dominant concept in science. This makes me worry. Where does research go and where should research go? So this is obviously a problem, I would say.
Thank you, Sharon.
Well, I don't know, maybe I can talk about a little bit about the feelings because I also started in this project from very scratch and there was a little bit gap in between. But while doing literature review, I was like, I was thinking maybe we will get some very straightforward answers, but going forward, this was with the survey was with the stakeholders. It's not with the general population. And when we talk about stakeholders and the people working on addiction, they have gathered so long experience and education. So I think this was expected that they would not choose a side. They would not be very specific. So it is still we don't know yet, but I think the result is quite they don't say that this is exactly the brain disease model. They don't support in a way, but it's still on third highest if we see the data. So maybe in reality it's different, but theoretically they support.
Okay, Bruce, are you happy? Can we go to Paul then next?
Thank you. I'm interested in particularly the professions, the judicial or the juridical arena. Do you think did you come up with any information on how legal people, judges or any kind view or take in this brain disease idea into their considerations in court, for instance, and that has to do with ideas of accountability or liability or responsibility for their actions while being intoxicated or pre-intoxicated or whatever, in acquiring money, so theft or anything that to provide for their drug. Could you see any change how legal people think about this condition of addiction in face of the brain disease?
We also conducted a survey amongst the German representatives of the legal and forensic system. That was the wish from the advisors. And we know from literature there's a survey among US American advocates, I think, and we included a sample of US American criminal justice students. It was a cooperation with another partner from Rutgers University. And we can see great differences between the systems and the representatives. In Germany, it does not really play a role. People say, well, it's important, we consider it important, but in our system, we don't have time, we don't know, it does not play a role, and we're not really informed, and we cannot, but maybe it should. It's a completely different picture in the United States of America. We know this from the survey, and also the students confirm this. They are interested, they consider it different. There's also a handbook on these issues, on neuroscience in the law or something, I don't know exactly how. And on neuroforensics, they have handbooks on that, how to deal with methodology issues and how to interpret this, as these legal representatives are not really don't know the basic facts and how to interpret the results. So there are really broad differences, but what they have in common all is that nearly all of them, the vast majority, say people are responsible for what they do. So this is the most important question in this connection, at least for the Germans. They say we have to decide on whether people are responsible for what they did. And they all say, no matter whether it's a brain disease or not, people are responsible.
Okay, thank you.
Thank you. We've got time for one more question, I think, or one more discussion point, if anyone would like to step forward.
I might have one more.
Go for it, Paul.
One topic is if you talk about stigma, stigmatizing a person as a patient or as a diseased or a brain diseased person, that when you deal with a situation like that between a doctor providing treatment or the professionals providing treatment and the patient itself, how much is treatment affected by when the two sides, the patient and the professional, have different views on the causation of the condition of the patient or the person involved? So it kind of concordance or discordance between patient and the professional. That in medical sociology has always been a hot debated topic, of course, in that, in order to get good treatment, for instance, you have to be a good patient. And to be a good patient, you have to adopt a doctor's view of the causation of your condition. Otherwise, you run into difficulty. So did you come up with any ideas about that, between how the interaction between patient and professional plays a role, or in which this model idea, model paradigmatic ideas of the disease or the condition affects this interaction between patient and professional?
Anyone?
This maybe did not come now directly from our data, but thinking about the literature, I think this is voiced as one criticism against the brain model, that it somehow professionalizes the experience of addiction and takes away the experience of the persons with having the problems themselves. So in that way, this is something to keep in mind when the brain disorder model of addiction would take more space, because the diagnosis and so forth, it demands like a very precise knowledge and very deep knowledge about brain images and so forth. I mean, most of the persons can't read the brain images anyway. So, and that they, of course, there's obviously also like a power dimension in it, and it definitely does not empower the persons in treatment then. But this is now nothing that I would say came directly out of the treatment data.
Anyone else, or indeed any of our speakers or indeed participants want to come in on anything? Final opportunity for final questions. Well, if no one's got any more questions, it falls to me to just thank all our 4 speakers for a brilliant seminar today, and indeed for a hell of amount of work and pulling it all together into telling a coherent narrative is pretty impressive. So thank you from us all, and I hope to see you all at the next Addiction Theory Network's webinar, which will be in the autumn, I suspect. Thank you all.
Thank you. Bye-bye.